welcome.
Our first question is about patients with AIDS have a significantly higher risk of NHL than general population. The essence of AIDS-related lymphoma is canceration of the immune cell. Could you please introduce the pathogenesis of NHL?
Well, with the caveat that I'm not a molecular biologist and just a clinician who treats patients with lymphoma, I think the basic principle why patients with HIV infection, as with other immunodeficiencies, develop lymphomas much more frequent than otherwise healthy individuals is the fact that their immune system is unable to cope with chronic viral infections that are known to cause lymphomas like EBV or CMV. And to a lesser extent, in the case of HIV, by direct insertion of the virus into the genome of a lymphocyte.
Here's our second question. At this Congress, you chaired over a special section this morning on human immunodeficiency virus associated lymphoma. Could you please talk about the updates of ARL guidelines and amounts of ARL treatment this year, like the EHA National Clinical Practice Guidelines?
Exactly. Well, some 2 years ago, we started the project of renewing the recommendations for treatment of HIV-related lymphomas or lymphomas in persons living with HIV. And finally, we got to the point where they are going to be published and presented. 20 years or so since the introduction of highly active antiretroviral therapy is the fact that both responses and tolerability of patients with HIV to treatment become similar to that of immunocompetent individuals. So the differences in approach to the treatment of common entities is becoming smaller and smaller. Saying that, there are also some disease entities that occur specifically in patients with severe immunodeficiencies, including HIV, and then they need special guidelines for these because they do not simply occur in the immunocompetent individuals. And when treating lymphoma in these patients, you always have to consider the interaction between drugs used for viral treatment, drug used for infectious prophylaxis, and drugs used for treatment of lymphomas. And what is most important, it's not very new, but still most important, not to stop the antiretroviral medication while treating the lymphoma.
Our last question. In this special section, there are clinical case and panel discussions.
Right.
Could you please share some of the important contents of these clinical cases and discussions?
Well, the clinical case was a very interesting and tough one. It was actually a patient who presented with a previously unknown HIV infection, secondary infections, tuberculosis and so on, and lymphoma at approximately the same time, so he was really very immunosuppressed. It was interesting to see how these problems occurred one after another and how they did respond to treatment of the lymphoma, but together with treatment of HIV. And during the panel discussion, well, there were very many questions from the audience, more than I actually expected, suggesting that really this topic is still, doctors who treat lymphomas still need guidelines when they see a patient who's also HIV infected, that they know how to behave and how to treat both diseases at the same time. There are many questions related to special aspects and also to treatment of multicentric Castleman's disease, HHV-8, and so on, which are specific for this patient population. Oh, good.
Kind of like the ending.
See you next year in Milano for the HAA annual meeting in 2025.